Hi there. Thank you for joining us this evening for the Herts Essex Fertility Centre open evening. My name's Gemma. I'm one of the embryologists that works here at the centre. And the plan for this evening is that I will run through a presentation that we have, which just sort of outlines many of the services that we can provide at Herts Essex, a bit more about what we do, and also to give you some more information to help you on your fertility journey, depending on where you are in that process. We'll also include kind of a run through of what a standard IVF cycle looks like. That, of course, wouldn't necessarily apply to everybody, but we've tried to do a sort of a catch-all to give you a better picture. So as part of the presentation this evening, there's also the Q&A. So on the Teams call, you can see there's a section called Q&A. If you write any questions that you have in there, we'll be able to monitor them throughout the presentation and also afterwards, and we'll try to get back to you with answers. If you've got questions that are really specific to yourselves or to your medical history, then we may not be able to give you an answer this evening, but we'll be able to check out what we need to find out for you and get back to you tomorrow. We also ask you for feedback on how the presentation has been useful and how, if there's anything that we've sort of missed out that you'd have liked to have known more about, please do let us know, because we run these evenings quite regularly and we want to make sure that everyone who attends gets all the info that they need, so that will help us for next time. At the end of the presentation, we also have a video, which is a series of scenes that have been shot in and around the clinic to give you a bit of a picture of what it's like when you ever do attend here in person. With an online evening, of course, we want you to still feel that you get an indication of what the clinic's like, so that's what that video is for. We also have a special discount offer. Because you've attended this evening, you're eligible to take up that discount offer to get a reduced rate on some of the services that we offer, so we'll go through that at the end as well. So, as I say, I'm Gemma. I'm one of the senior clinical embryologists here. We also have this evening Jackie, who's one of our fertility nurse coordinators. She's on our online Q&A this evening, so she'll be the one responding to your messages whilst I'm talking. And we also have Mana Marks, who's our marketing and wellness manager as well. And she's on here if there's any issues with the stream this evening, or if you're having problems with sound or picture quality, drop a message in the question and answer section, and she will be able to try to sort that out for you. She'll also, of course, be able to answer questions about Herts Essex as well. So a brief bit about our history. We were founded back in 1989, and since then we've therefore had over 36 years of experience in the field. So there are a few clinics that are a bit older than us, but not too many. So we really do know, how the field has changed, and make sure that we keep up to date with all the new developments as time's gone on. And as a result, there's been over 8,000 babies that have already been born as a result of treatment under the Herts Essex sort of branding. And all of our procedures are performed under the one roof. So the Herts Essex Fertility Centre, which is located in Cheshunt, is a standalone purpose-built clinic. And as part of that, that means that you would attend here for anything that we need you to attend in person. So blood tests, if you're having eggs collected or sperm collected, and embryo transfers, all done on site. So there wouldn't be any need for you to have to go anywhere else for your fertility treatment. We offer a really wide range of services, starting really from assessments. So if you're considering starting to try for a family, or if you are concerned that there may be something in your medical history that might be a barrier to conceiving, we can look into those things for you, whether that's as an individual or as a couple, regardless of your sex or gender. We also offer gynecological screening. We are aware that there's, often really quite long waiting lists in the NHS. So where possible, we try to offer screening for a variety of gynecological things, many of which are connected to fertility. And therefore, you can have screening with us to try to keep the ball rolling, even if you're looking to have actual fertility treatment elsewhere or not have treatment at all. We have a dedicated donation and surrogacy team at Herts Essex as well. So that's including people who are using donor sperm, donor eggs, or a surrogate. And through those schemes, we're able to help people and support you through what can be quite a complicated process, particularly because of the legislation that's involved around donation and surrogacy. And we have a lot of expertise in that. We can perform IUI procedures. So this is where sperm is collected, washed, and then placed directly into the uterus at the right time. This is a really good option for many couples and individuals, and I will talk briefly about that later on. We can do fertility preservation. So even if you're not planning to try to conceive in the near future, we can help you to store your sperm, eggs, or embryos so that they're available for the future. We can, but if you are looking to conceive in the sort of nearer term, we can also offer that. So that would be a standard IVF. So that's in vitro fertilization, where sperm and eggs mix together to create embryos. And we can also do additional processes as part of that, including ICSI and PICSI, which are useful tools if you are certain groups of patients who would benefit from those. We have additional treatments that we can offer as well, which are sort of added in as part of the pathway, dependent on which other bits you're taking on. Everything we do is bespoke. We make sure that what we're offering you is correct and right for yourselves, and we can guide you through what treatments we think you may benefit from specifically. We then go all the way up to pregnancy scanning. So if you are fortunate enough to fall pregnant, whether through treatment or naturally, we are able to provide early scans to just check on the health of that pregnancy, offer reassurance, and also to then, if you have had treatment here, to then hopefully discharge you back to your antenatal care, which is usually done on the NHS. So starting with the fertility assessments, we have what we call the couple fertility assessment. This is really designed for heterosexual couples, so where one of you will be providing eggs and the uterus and the other would be providing sperm. And what we're doing here is we're looking to just check that all of your sort of general markers of fertility health are all looking healthy. And if there's any concerns or barriers that we can potentially see to you conceiving either naturally or through IVF, we can flag those at that point and advise you and signpost you on what might be good next steps to consider. We have also the female fertility assessment. This is where we're just looking at one person. We're looking really to assess your ovaries and also your uterus for suitability for creating embryos and carrying pregnancies. And then we have the male fertility assessment, which is for people who produce sperm, where we're able to look at the semen, and then from that we can give you a call and we can discuss whether or not your sperm is like that of men with a known fertility status. And that can be really useful in helping you to kind of manage expectations as to whether or not you're likely to conceive naturally, whether or not you may benefit from any fertility treatment, but also to offer advice on a sort of healthy lifestyle and any adjustments that you might be able to make to improve your fertility. And that goes really for all three of the different types of fertility assessment. We can support you in whichever way really you want to proceed from there. As part of looking at people who are looking to carry pregnancies, we can do 3D ultrasound assessments. So for these, we do gynecological scans. We offer two major types. These are the cis or the hycosi, and these are looking to see whether or not the uterus has any abnormalities. So in this ultrasound picture, the black and white one, you can see this large black cavity. This is the center of the womb. But in this one, we have a polyp which has grown in that cavity, and that could potentially get in the way of a pregnancy establishing. So we're looking for things like that. The hycosi also has an additional layer where we look to see whether or not the fallopian tubes are open, because that is obviously another way in which we may see a barrier. If this is physically obstructed in any way, then we may not be able to get sperm and eggs to meet in the natural environment. When we talk about fertility and sort of things that you can do practically to try to improve your chances of conceiving, either naturally or through treatment, being fit for fertility is really important. We have a standalone website which is connected to our main website, where we try to give you more advice on sort of the healthy lifestyle changes that you might be able to make to maximize your chances of conceiving. So that's a really good resource, and I would recommend that you go on there. You can access that anytime, whether you're a patient or not, and it's just got a lot of good signposting and information on there. So if we talk through sort of what a standard treatment cycle might look like, as I said before, there is really no such thing as a standard treatment cycle, because everything we do is dependent on your own history and whether or not you're coming with a partner and their history. But generally, there is a sort of pathway that's followed. So it begins with a platform called Fertility Consents. This is an online platform where we'll send you some login details. On there, there's a lot of information about fertility treatment and also some consent forms which would need you to sign. As I said before, the sector that we work in, the fertility field, is very highly regulated. And that can be a frustrating thing because it means there's a lot more paperwork than in other healthcare settings. But it's also a really good thing because it protects you and it protects any children that are born as a result of your treatment. So those consent forms need to be started before we can really go any further. We also ask you to upload any relevant investigations that you might have already had elsewhere. We don't want to have to repeat any tests or findings that you've already got. There's absolutely no sense in doing that if you've still got in-date investigation results that are valid. We're not in the business of repeating things unnecessarily. So please do share with us anything that you have, and then we can work out whether or not they do need repeats because of time that's passed between them and now, or if there's anything additional that we might want to investigate too. At this point, we also ask you to consider signing up for the Salve app. We'd send you the details at this point. It's a really powerful app in that it allows you to track any medication that you're prescribed as part of your fertility treatment. It sends you reminders about all of your appointments. And the thing that we find most useful in the embryology lab is the secure messaging service. So if you have any questions and would like to speak to any member of the team, you can send a message on there. It kind of works like a WhatsApp situation in that we'll then pick them up and reply to you. But the really important thing is it's completely secure. So we know that any information that we put in there, we can discuss confidentially. We know we're definitely talking to the right patient. You know you're definitely talking to the right clinic. So that's a really useful tool that we recommend. Once all of that's done, we've got everything sort of lined up, you then attend for a pre-assessment. This is done in person because we will need to take blood tests from most of the people who will be involved in your treatment, and there'll be nurse observations as well. For people who are providing eggs, we will also try to test for your AMH and thyroid function, provided that you haven't already had those done recently elsewhere. The other thing that we need to look at is BMI. We measure BMI for everybody for two reasons. The first main reason is that it has been shown that people with high BMIs have a poorer chance of success. That's not to say that you can't have treatment if you're heavier. It's just that we need to take that into account when we're trying to work out for you what treatments are the best ones to offer you to try to get you to the best outcomes we can. The second thing is that if you're having a sedation as part of your treatment, so that would be people having an egg collection or a surgical sperm collection, we need you to have a BMI of under 34. And that's because as a standalone clinic, we're not connected to a larger hospital. It's not safe for us to sedate people who are heavier than that BMI bracket. And so we don't want to put you at any additional risk of becoming unwell. So if you find that your BMI is higher, we have lots of tools available to try to help you to get that down so that you can safely have your treatment. But just to make you aware that you will be required to have your height and weight measured. If you're providing sperm, we'll also ask you to provide a semen assessment sample as well. Depending on where you live, you may be able to do that at home and then just drop the sample off. Just drop the sample off at the clinic. We have to do the analysis ideally within an hour. So if you live further away than that, then you'll be asked to attend the clinic and produce your sample on site. If you have any concerns, we know that a lot of people do struggle to produce their sperm samples. It's such an artificial thing to have to do. So please don't stress about that. If you have any concerns at all, let us know. And we have lots of things we can try to put in place to make that process a simpler and less daunting one. Once we've done all of that, we then move on to the consultation. This is usually done remotely. We can do in-person consultations as well, but obviously that means then you have to both attend the clinic, which can just make it much more difficult to organise, and we don't want to cause any delays. So generally this is done online. We send you an invitation code for Teams in the morning, and then at the consultation, the doctor will have all the results that have already been sent through, all the results from your pre-assessment. They'll be able to discuss with you what they're seeing and whether or not there's anything there that they think we need to consider. And then together, yourselves and the doctor then work out a treatment plan. These are just options that you can explore. There's absolutely no obligation to proceed with any of them, but it's just a way of saying, you know, based on what we're seeing here, this is what we think you could benefit from. This is how we think you might want to proceed. And they'll give you lots of options for additional things that you might want to consider if you do decide to have treatment. Now, if you do decide to proceed with treatment, we do require additional screening bloods for anyone who's providing sperm and eggs and or using their uterus. And we also require screening for partners of people who are in the other categories. So the big ones are HIV, hepatitis B, and hepatitis C. It's a legal obligation that we screen you for these, and we need to know whether or not you have them. It's not a problem if you do, it's just that we need to be aware because it changes the way that we process and also the way that we store your sperm, eggs, and embryos. We also screen for chlamydia and gonorrhea routinely as well. So all of those things need to be tested. And if you haven't already had it, then we would also do your AMH, and for people who are planning to fall pregnant, rubella, full blood count, and your hemoglobin electrophoresis as well, because these are things that are important considerations for if you were to fall pregnant. Again, it's not necessarily going to be a barrier to treatment, it's just something that we need to know so that if you are successful, we can be making sure that everything's proceeding safely from the off. All of these bloods need to be done within 3 months of having your eggs or sperm collected. So what we don't want to do is do this too early. So when you come through for your consultation, we'll discuss with you then when your timelines what timelines you're envisaging for having treatment, and we'll make sure that these bloods are done at an appropriate time, dependent on your next steps. So IUI is one of the sort of less invasive treatments that we can offer. This is a procedure where we take a sperm sample and we process it in the laboratory to try to collect out the sperm that are the healthiest from this. And we're doing that by looking at ones that are swimming nicely, that are shaped well, and we try to concentrate that. And then we place them directly into the womb at the time that we believe ovulation is around about the time of ovulation. So IUI is a really powerful tool, particularly for heterosexual couples who are unable to have sex. So if you're somebody who suffers with psychosexual problems, vaginismus, erectile dysfunction, even severe premature ejaculation, that are barriers to actually having intercourse, then we are most likely then, if your sperm sample comes back with a normal result, your tubes are open, then we think that most likely the barrier is the fact that we're not getting the sperm and eggs together in the uterus at the right time, in which case IUI can be a really good tool to overcome that problem. It's also a good choice for people who are using their own eggs and uterus but are using donor sperm, because again, the issue here is not necessarily that the sperm and eggs are not functioning, it's just that they don't get an opportunity to meet. Now, there are lots of reasons why IUI might not be an appropriate option for you, and the doctor will go through that with you at your consultation. But for many people that fall into the categories listed, that's actually a good first choice to consider. But if you're someone for whom IUI is inappropriate, or if you're further down the pathway already and it's time to start considering IVF, then I can just talk you through now what that treatment pathway might look like. So generally, we start the process by tracking from your period. So from the first day of your period, we then ask you to call in and let us know that you've started your cycle, and then we'll get you in for an ultrasound scan. We then, dependent on the findings of that scan, will start your first stimulation drug. So what we're trying to do here is we're trying to stimulate the ovaries and encourage follicles to grow. Ordinarily in a cycle, many follicles start to grow and then one of them kind of takes over and suppresses the other. But what we want to do in an IVF cycle is to encourage all of those follicles to grow so that we can collect an egg from each one. So the medications that we give you encourage those ovaries to encourage all of the follicles to grow. And we continue taking these injections every day up until a couple of days before your egg collection. There are some side effects to these medications. First of all, they're usually done via injection, which means that can be a little uncomfortable. If you're particularly concerned about injections, please do speak to the nursing team because they have lots of tips and tricks to try to make that process easier. But the other side effects that we see are really from the fact that these drugs are hormone-based. So we often see people presenting with headaches, mood swings, breast tenderness, bloating. Generally, the kinds of side effects that you may have throughout your period cycle anyway, but there will likely be a little bit worse than usual because we've got so many more eggs growing and you're having such higher doses of the hormones than what your body would naturally produce. But as I say, most people are able to tolerate these fairly well. So we'll be scanning you throughout the process of your daily injections. We try to make sure that we bring you in as few times as we can while still getting enough information. We don't want you to have to constantly be attending the clinic for scanning, but generally most people will have between 1 and 4 scans. So once we see that your ovaries are starting to respond, you can see here in this ultrasound image, the black sections are the follicles. These are fluid-filled areas in the ovary. And once we can see that your ovaries are responding and they're starting to grow, what we then need to do is stop you from naturally ovulating. So we give you a second drug, which is often cetrotide, but there are many others, and we'll determine which one is most appropriate for you at your consultation. When we see that your ovaries are getting ready, we'll start to administer this drug to stop the ovulation. But then we need to continue to monitor to make sure that your follicles are still developing and that your endometrium, so that's in your uterus, is getting ready to receive the embryos. Now, each scan is done with the person who scans you. They will be able to let you know how your ovaries are getting on. You then walk across the hall and go and speak to a nurse. And the nurse will go through with you what your next steps are, if there's any changes to your medication, and answer any questions that you might have at that part of the process. We're really aware that there's lots and lots of steps to IVF, and we don't want to overwhelm you. So what we generally do is provide you with all the information of what the whole process is going to look like, all at the beginning, but then after every single step, we just check in with you, make sure that you know where you're up to, what your next steps are going to be, so that you don't have to try to remember the whole process all the way through. And eventually you'll have a scan where hopefully what we'll see is that the endometrium in the uterus is getting ready to receive the embryo. Now, at this point, we see this sort of 3 white lines on the ultrasound scan. This tells us that the endometrium is getting nice and thick, and at this point we'd also be checking to make sure that your ovaries are still full of follicles and that they're ready and happy to start considering having the eggs harvested. At your final scan, when we decide that actually it's time, what we would do is we would give you a time and date for your egg collection. We give you all the information about being admitted into theatre. And the most important sort of one point in your cycle really that you need to focus on is having your trigger injection. So this medication is one final injection, and this tells your ovaries that it's going to be time to have those eggs collected, and those eggs will then start to mature. And the timing of this is really critical. This is always given at an exact time before your egg collection. So we make sure that you have all the instructions that you need about taking that in a verbal form. You also have them written, and if you're using the Salve app, they'll also be on there as well. So it's a sort of the biggest part of the process. Lots of people get very anxious about it. There's no need to be anxious, but you just need to be mindful that it is critical that you take it at the right time. So if you have any concerns, you just let us know. We're always available, and we can talk you through any problems there. You then are going to have your egg collection or your egg recovery. And the process for this is that you are admitted into our recovery bay, which is within the clinic. At that point, we take some baseline observations, check your heart rate, check your blood pressure. And if you're providing a sperm sample on that day, then the sperm provider is asked to go and produce their sample on site, usually. Once that's done, we then sedate the person having the egg collection, and the procedure is undertaken using an ultrasound guidance method. So essentially the doctor will go in and take the eggs out of or hopefully the eggs out of the follicles by draining each follicle. Now, the sedation that you're given here is what we call a deep sedation. So it's not quite a general anaesthetic, but most patients are not really aware of what's going on, and very, very few of them will actually remember the procedure at all. But the good thing with deep sedation is that actually your recovery from that can be quite quick. So within a couple of hours after the procedure, you're usually well enough to go home. Some people do still feel a bit groggy. So what we would usually advise is that for the next 24 hours, take things easy. And we ask that you don't sort of make any major life decisions or, operate any heavy machinery, all those sorts of things, because you have just had quite a powerful sedation. And then you're free to go home. And that's when people in the lab, like myself, then come into play. So all the timings that you've had so far have all been based on the number of days after the beginning of your period. In the lab, as an embryologist, our day count starts from the day that the embryo is created, and that happens on day 0. So the egg collection happens on day 0, and we can do a number of things with those eggs. The first thing we might be doing is egg freezing. So over the last few years, the process of freezing eggs has gotten better and better, and we're now at a point where the vast majority of eggs survive being frozen and thawed out. So what we can do is collect eggs and freeze them to preserve future fertility. We have a legal framework around this, which means we're now able to store your eggs for up to potentially 55 years. So for most people, that's more than enough time to complete their family. We know that the quality of our eggs and sperm will be better when we are younger, to a point, but that's not to say that it's ever sort of considered to be too late to freeze your eggs based on age alone. So if this is something that you're considering, it's absolutely worth investigating and getting some advice on. Many people are freezing their eggs for social reasons. They know they want to have a family in the future, but they're not quite there yet. Or people who are concerned about going through early menopause may wish to freeze their eggs whilst they're still in a fertile point in their lives. And also people who are undertaking cancer treatments or any sorts of surgery that may impact their fertility in the future. And counselling is offered to all of our patients. Anyone having fertility treatment of any kind is eligible for counselling with our specialist fertility counsellors. And this is often a really good idea for people who are egg freezing, because we're often thinking about, well, what do we want to do in the future rather than just what we want to do now. But the majority of people who have an egg collection will be having some sort of insemination. So when we talk about IVF treatment, this really is sort of a catch-all for all kinds of treatment where we put sperm and eggs together. But in the lab, when we say IVF, we really mean traditional IVF, where we add sperm and eggs together in a dish and we allow the sperm to swim their own way into the eggs to fertilise them. This is a good option for people who have normal sperm parameters. So if you have had a new consultation appointment with us, and your sperm parameters have come back normal, then we may say it's worthwhile considering IVF as the first port of call. We wouldn't recommend it for people who have low sperm counts, poor motility, or abnormally shaped sperm, because what we don't want is those sperm that are not as healthy to be the ones to get to that egg first, or for there to just not be a high enough concentration of healthy sperm to be able to reliably fertilise the eggs. If you've had ICSI in the past, we generally don't go back to IVF, because ICSI is sort of something where we're getting over a few additional hurdles, and we wouldn't want to find out by trying IVF after having a successful ICSI cycle that actually some of those hurdles are the reason why ICSI worked and that you needed it. So ICSI itself stands for intracytoplasmic sperm injection, and this is the one that you often see on the news, where you inject one sperm into one egg. As I said, this is a really useful tool for people who have low sperm counts, motility or abnormal sperm, because I only need as many sperm as there are eggs. And what we do is we choose the best of the bunch and we pop those into the eggs one at a time. So even if you've got particularly poor sperm, we're still able to get good fertilization from ICSI, overcoming many of the issues that we may have seen in IVF. It's also a good choice for people who have no sperm in their ejaculate. So if you're somebody who is what we call azoospermic, then it may be that we can retrieve sperm from your body using a small surgery, and then those sperm are able to be used, as long as your body is still making the sperm for us to collect. Some people may find that they're MAR positive. This is a test that we perform at the new consultation semen analysis. And essentially it means that the sperm have antibodies against themselves and they can get stuck together. And when that happens, it means they're not free to swim to the eggs. So in IVF or in a natural conception, they could potentially be getting in each other's way. If you've previously had IVF treatment using the standard IVF, then we may recommend that you use ICSI on the next time, because as I say, there are some barriers potentially to IVF. Sometimes sperm and eggs don't interact, even though they all appear to be normal. So if we go to ICSI, then the sperm and eggs have no choice but to interact, because I'm going to be physically putting them together. ICSI is also the first option that we would use for people using frozen eggs, whether that's their own or somebody else's. Partly because the freezing process can make the shell of the eggs particularly tough, and then the sperm can't swim their own way in. So that's another factor to consider. Now, we then have a video, which I'm hoping will play for us today. Yes, lovely. So here, this is an ICSI procedure. So you can see that sperm there swimming across the screen. There's another one there that's not swimming anywhere. So the practitioner who is performing this ICSI is going to look around the dish and try to find a sperm that they think is swimming nicely, has the right shape, and generally looks like one that could be a healthy sperm. So what they'll need to do is they'll find a sperm, which they've just seen off the screen, and they strike it across the tail a couple of times. And this will immobilize the sperm. That's important because once it gets into the egg, you don't want it thrashing about in there, causing havoc. So we make sure it's immobilized so that when the sperm goes into the egg, it's not going to do any damage. Now, we've zoomed out a little bit here, but you can see there we're holding this egg using the needle on the left-hand side. And we know that this egg is mature and is looking to receive a sperm because it's got that little polar body, that little structure at the bottom. We then bring the sperm to the end of the needle, we go through the shell and then in through the membrane. And that membrane is quite stretchy, so we then suck back on it until it pops like that. We see the little whoosh, and then we put the everything that we've just sucked out and also the sperm into the center of that egg. Now it looks really harsh, and you can see that sort of funneling there where the needle's gone in, and it does look really harsh. I'll give you that. But eggs are generally very robust, and within a few moments that funneling will have calmed down, and it would actually be very difficult even for the person who's done the injection to be sure that there was definitely injection that happened, because they bounce back so well. That said, there is a small proportion of eggs that don't survive an ICSI procedure. Some eggs are not even suitable for an ICSI procedure once we collect them. If they're immature and they don't have that little polar body structure, that tells us that it doesn't matter how much sperm you put in there, they're never going to be able to turn into embryos because they're not ready. But then even the ones that are ready, sometimes what we see is that they're not as robust as we hoped they would be, and as you put the needle in, they start to degenerate. We'll never know whether or not those eggs would have been able to fertilise using another method, but generally, if we're offering you ICSI, it's because we think that the balance of sort of getting to the best fertilisation result that we can lies in the favour of going for the ICSI, knowing that there's this potential risk of egg damage. So let's not watch that one again. Let's go forward. So as I say, those are like the main two insemination methods, but we also can offer PICSI. This is a variation on the ICSI process. The difference really is how we select the sperm. So if you've had your new consultation semen analysis or an analysis elsewhere that has done HbA testing, what this does is it looks for sperm that are able to bind to a protein which is found on the egg. And we know that only mature sperm can bind to this protein, and only mature sperm can fertilise an egg. So if you have a low maturity score, then what we can do is coat a dish with this protein and then select only the sperm that have bound down, so that way we know the sperm we're collecting to put into the egg is a mature one. We don't need to do this for everybody, because if you have a very high proportion of sperm that are mature anyway, chances are the sperm we pick is going to be a mature one. This is more just for people who have a concern that there may be a higher proportion of immature sperm that otherwise look normal. So these are all options that we would explore with you based on the results of your semen analysis and your medical history. Then on day one, we will assess to see whether or not we've been able to create embryos. So this is the fertilization check. We would normally give you a ring once we've done this assessment. What we're looking for is one that looks like the embryo here on the left, where there's two structures in the middle, two little sort of circles. These are the two bits of DNA, one hopefully from the egg and one from the sperm. If we see these two structures, that would tell us that this egg has likely fertilized normally and therefore has a really good chance of developing into an embryo. The one on the right, however, you can see there's three of these structures. And this can happen from time to time. It may be an indication that there's an issue with the egg, or it might be that there was an issue with the sperm, or sometimes, particularly with IVF, it may be that two sperm managed to get in at the same time. And because of this, it has too much DNA inside of it. It's not normal, and therefore the chances of it going on to give you a healthy embryo and ultimately a healthy baby is incredibly small. So we don't continue to grow these embryos. So what we would do is call you at fertilization check, let you know how many embryos you have, and then advise you on what we think the next steps need to be for your treatment. On days 2 and 3, the embryos start to develop into cleavage stage embryos. So at this point, the egg divides sort of in a 1 becomes 2, becomes 4, becomes 8 pattern, but there's ever so slight variations on this. They won't all happen at exactly the same time. So it's entirely possible to end up with odd numbers. But as long as those cells look nice and healthy, like these two pictures here, they're nice and round, they're similar and even in size, there's not too many sort of fragments that have fallen out, they're nice looking embryos, we can consider doing an embryo transfer on day 2 or 3. However, we generally only recommend this if you're having back all of the embryos that are created. So for example, if you have one embryo, then whether it goes back on day 2, day 3, or day 5, its chances and its potential remain the same. The benefit of that obviously is that if you feel strongly that you really want to get to the embryo transfer stage, then we may as well get it back to you sooner and we can get that done. The downside, however, is that when embryos are still at this stage, we don't have as much information about their potential. By allowing them to grow for longer, the ones that are stronger, the ones that have a better chance of giving you a healthy pregnancy, will develop more rapidly and more sort of robustly than others. So if we wait until day 5, we get more information about that embryo. As I say, the chances of the embryo giving you a pregnancy remain exactly the same because it's the same embryo. The difference is whether or not we know more information. And if those embryos fail to develop by day 5, that's an indication that they're incredibly unlikely to have ever been able to give you a pregnancy. And we can cancel the embryo transfer and not put you through the 2-week wait when we now know that there's an issue with the embryo. We also find that with the day 2 and day 3 embryo transfers, if you have that embryo back and it's an unsuccessful cycle, we won't know if it's an embryo problem or a uterus problem or something else. Whereas by waiting until day 5, we know at least it was a good embryo that we put back, and therefore it helps us to work out next steps if for any reason this cycle should be unsuccessful. But we would discuss all of that with you when you have your fertilization check call, if you're in a situation where you've got all the embryos that you have planned to go back. Now on day 4, we don't assess the embryos at all. We also wouldn't look at the embryos on day 2 and 3 if we've planned you for a day 5 transfer. On day 4, the embryos kind of collapse down. They go through a process called compaction, where they essentially remodel themselves and start to develop into something new. And during this point, it's incredibly difficult to see anything meaningful that we would use as a sort of a clinical indicator to decide what to do. So we leave them undisturbed. We just want those embryos to stay nice and warm, nice and safe in the incubators, and we leave them alone. But on day 5 is when they should have hopefully started to reach the blastocyst stage. So the picture on the right here is a particularly nice blastocyst. You can see at the sort of 11 o'clock point on the embryo, if you look at it as a clock face, this is the inner cell mass. This is the part that will go on to become the fetus if it can, and all the rest of the structures will go on to become the placenta. And by looking at those two structures and also how developed the embryo is, we can try to indicate to ourselves what the chances of success here might be. So this embryo is already starting to hatch out, which you can see at like the 3 to 4 o'clock point, which tells us it's getting ready to try to implant. The inner cell mass is really nice and compacted, it looks strong, and the cells that make up the trophectoderm that will become the placenta also look really nice. So this embryo would absolutely be suitable for embryo transfer, and most likely also for any of the other things we might do with an embryo on day 5. So embryo transfers at Herts Essex, they take place 7 days a week. So you don't need to worry about what day your period started, what day of the week your egg collection was. We will do the embryo transfer when the embryo is ready and when your uterus is ready. There is no sort of difference between people who are having an embryo transfer on a Monday or a Sunday or a Thursday. We do it based on the embryo and the uterus for you. Now, when we do the transfer, we will assess them in the laboratory first of all. We take a photograph and we get them ready for the transfer based on our recommendation. When you arrive at the clinic, we talk you through what we've seen, what we're recommending, and we give you an opportunity to see the embryo on the screen. At that point, if you feel strongly that you'd like to do something different to the recommendation, we can absolutely discuss that. And sometimes there are ways in which we can make changes to the plan based on either the number of embryos you're having back and things like that. We can discuss it all when it's no longer hypothetical and we actually know how your embryos are developing. We offer a service called Embryo Glue. This is for all patients who are not funded by the NHS. It's essentially a culture medium, so it's a liquid that your embryo is placed into. And it tries to mimic the conditions in a healthy uterus to help an embryo to implant during the transfer process. It's considered to be an add-on by the HFEA, so our regulator. We know that if we offered it and everyone took it up across the whole board, it's not going to increase the number of pregnancies that we see healthily, and it's not going to sort of be significant in the numbers that we see. However, it has been shown that in some patient groups, particularly people who suffer from repeated implantation failure, it may be of benefit to those groups. So we offer it to everybody because rather than finding out that you're somebody who has repeated implantation failure and would benefit from embryo glue, you have the opportunity to use it from day one. But it is important that you bear in mind that this is an additional cost. And as I say, the evidence that it will help everybody is not quite there. But it's a perfectly safe process, and many patients choose to use it. If you're in the NHS funding stream, then you're not eligible to use embryo glue, and I wouldn't want you to be concerned about that. Embryo glue just has a really good name, but essentially the culture media that we use as standard also contains many of the same components. It just doesn't have that additional layer of being shown to help for people with recurrent implantation failure. The other thing we can do on day 5 is biopsy. So we can take a section from the trophectoderm, so from the part that will go on to become the placenta, and we cut it off and we send it off for genetic analysis at another lab. Now, again, it looks like a really harsh process, and it can be quite difficult for an embryo when we take these cells away. So we're only able to do it on embryos that are particularly strong and robust. But when we assess the embryos to decide if they're suitable for biopsy, we would call you and let you know. We have a wealth of experience in being able to identify which embryos have a good chance of being able to get through this process with minimal damage. And PGT is a particularly powerful tool because it allows us to look at the DNA inside the cells that we take that represents the embryo. The main one that most patients will be aware of and perhaps might choose to use will be PGT-A. This is looking for aneuploidies. So when we have an embryo, we should have 2 copies of each chromosome within it, one from the sperm and one from the egg. And PGT-A counts the number of each chromosome in the cells that we send off for testing. And that's important because embryos that don't have 2 copies of each of the chromosomes are far less likely to give rise to a healthy pregnancy and ultimately a healthy baby. Some of them would not be able to implant at all. Others may implant but would result in miscarriage. And others still may go all the way to a pregnancy and even a birth, but those children may be affected by syndromes such as Down syndrome or Turner's and Klinefelter's. So by performing PGT-A, we're able to prioritise transferring back embryos that we know have the best chance of giving you a healthy pregnancy. We can also perform PGT-M and PGT-SR. These are for people who know that they have either a single gene disorder, so things like cystic fibrosis, Huntington's disease, BRCA1 and 2, or if you have a chromosomal rearrangement. Now, these rearrangements are usually things that either you know you have because your family are affected by it, or it may be something that's found as part of you being worked up after repeated previous miscarriages. If you're somebody who falls into the category of being eligible for these, then we can add that into your treatment cycle as well. And again, it's a matter of identifying which embryos are the ones that give you the best chance of a healthy pregnancy. It doesn't change whether or not the embryos are healthy, whether or not the embryos are normal. It's just about identifying them. So it's a selection tool to try to get you to having a healthy baby as soon as possible. Once we've done the biopsy, those embryos need to be frozen whilst we wait for the results to come back. We also freeze embryos if you've had a transfer of a lovely embryo and you've got more that are also really nice. In the past, there was a lot of sort of drive in IVF to put back multiple embryos. We really try to minimise that as much as possible now because we can safely freeze the second embryo and it will sit in the freezer. It won't know that any time is passing, and then we can thaw it out and give it back to you later. And that's important because we know that singleton pregnancies have much lower risks of things like preterm birth, preeclampsia, gestational diabetes even. So what we're trying to do is make sure that every embryo gets its best chance, and that is usually one at a time. So if we're freezing those embryos, then what we do is we select the ones that we think are strong enough to survive the process. Again, not every embryo will reach the blastocyst stage. Usually about 60% will make blastocysts, and of those, the number that are of sufficient quality for freezing will differ from patient to patient. We also will freeze your embryos if, as part of the treatment cycle, you've taken on all of your medication, your body's responded really well, but what we sometimes see is that actually you're overstimulated, and it can become quite dangerous for you to fall pregnant. So what we do is we freeze those embryos, wait for your body to recover and settle back down, and then we bring you back in for a frozen cycle where you get that embryo back. That means that that embryo is getting its chance in the healthiest place that it can. On day 6, we will check any embryos that we haven't transferred or frozen the day before and assess them again. Sometimes an embryo just needs a little bit more time. So if your embryo is not quite where we wanted it to be on day 5, please don't panic. We know that they don't all develop at the same rate. We'll assess them on day 6, and it's quite common for us to see that by day 6, we have more embryos that are reaching those stages for freezing. And that's when you then have your embryo transfer procedure. So for that, you come into the clinic, we get you ready in recovery, you walk across the room, across the corridor usually, into the theatre, and for most people you don't require sedation for this. It's a little bit like having a smear test, so there's a speculum procedure, your partner's able to come with you, or you can bring someone else for support, and then we get that embryo back into your uterus. We then provide you with more medication for your luteal support. And what that means is it's supporting your uterus to remain ready to take on that embryo and to support that early developing pregnancy. You then take your pregnancy test 16 days after the egg collection, or 16 days after when the egg collection would have been if we're using frozen eggs or embryos. So we just sort of work backwards based on embryo age. Once you've had your pregnancy test, then we are obviously hoping to see that that will be positive. And after that, we can bring you in for your early pregnancy scans. So the image on the left is probably taken from I think that's a week 6 to 7 embryo. And at this point, you can see that sort of the big, large black cavity. That's the cavity within the uterus. And then the little white bit is the embryo. Attached to that is the yolk sac. And that's what we're looking to see. We can usually aim to see a heartbeat from about halfway through about week 6 to week 7. So we'll book you in at an appropriate time to make sure that we can test the viability of that embryo, of that fetus rather, by doing the early scan. We can also offer a slightly later scan at 10 weeks and a NIPT testing. So what we do here is we take blood from the person carrying the pregnancy, and at that point there should be enough of the DNA of the fetus in your blood for us to be able to screen for things like Down syndrome, and also for trisomy 15 and 18. So this is Edwards and Patau's, so that we can be aware of if these conditions are likely to be affecting the pregnancy from as early a point as possible. So that's sort of how the treatment cycle looks. Obviously, there are some slight variations to consider. So people who require egg or sperm donation, the process is very similar. It's just a matter of making sure that we source those sperm and eggs through different means. So not necessarily through somebody producing on site, not necessarily through somebody having an egg collection on the same day. And these are good options for people who have perhaps gotten a little bit older, so they're not producing the eggs anymore. Men, for example, who have had chemotherapy may find that their sperm quality is reduced. Same for women who have had chemotherapy and radiation therapy. If you're somebody who is born with any sort of genetic disorders that affect your fertility, we can try to get around them that way. And for some people, if they have a hereditary condition in their family, even if they don't have a fertility problem, they may elect to use donor eggs or sperm so that they can make sure not to pass those diseases on to their children. Obviously, if either of you don't produce sperm or eggs in your couple, or as a single person, if you don't have access to both of these within your home, essentially, then you will need to look for donor eggs and sperm, and we can support you through that process. So as I said before, we do quite a lot of surrogacy here at Herts Essex. We've done over 380 cycles since 2012, and our dedicated surrogacy team will liaise between intended parents and surrogates. If you're also using an egg donor, then they can help you with sorting that out. And we offer this for heterosexual and same-sex male couples, but also for single people who are using their own sperm, or indeed even people using their eggs. We can offer two types of surrogacy. One of them is a full or host surrogacy. This is where the surrogate also is the egg donor or egg provider, and partial or straight surrogacy. So this is where we create the embryos and essentially put them back into a third person to carry the pregnancy. And we can support you through all of these. So the next thing to consider really is funding. Now, we know that the NHS waiting lists can be really long, but it is always worthwhile sort of checking with your NHS providers to see whether or not you're eligible. We have partnerships with 3 of the ICBs, and this is all based on where your GP is, not where you personally live. But if your GP is under any of these 3 ICBs, then you would potentially have the option of coming here for treatment. If you are eligible for the treatment to be funded by the NHS, what they usually do is provide you with a list of available clinics, and then you choose the one that you think is the best fit for yourselves. We have a button on our website, which is this one here that you can see, the NHS funded treatment one. If you click on that, it gives you a lot more information about the process. But generally, the North and East London ICB include these areas. I won't read them all out. I'll let you just have a quick scan and see if yours is there. The Mid and South Essex is these areas. And the North and Central London is these areas. It's important that you check whether or not you're eligible, because what we have found in the past is that many of these ICBs, if you've had privately funded fertility treatment elsewhere, you're then no longer eligible for the NHS funding, or perhaps not eligible for as many cycles of the NHS funding. So we wouldn't want you to preclude yourself from NHS funding by having fertility treatment privately first. So it's always worthwhile just checking with your GP where you stand. Many people, though, will not be eligible for funding, or they may find that the waiting lists are just so long that it just doesn't fit in with your plans for building your family. So there are other options as well. One of the things that we can do at Herts Essex is enrol you on our egg or sperm sharing schemes. So in these schemes, we essentially take people on who are prepared to become a donor themselves. And if you're medically eligible, then you can donate some of the eggs that are collected or some of your sperm samples so that other people can use them in treatment. And as part of that, we therefore fund your IVF for you. There are still some things that you would need to pay for, but many parts of it are essentially subsidised. So if that's something you're interested in, you just need to let us know, and we can put you in touch with the dedicated sharing team, and they can give you all that information for yourselves to think through. As I said before, we do have the autumn special offer on at the moment. This is running till the end of the month. So as you've attended today, your name is on our list of people who've attended for an open evening. And if you want to book in for your new consultation appointment, then the price is cut by 50%. You'll still need to pay for your blood tests and semen analysis if you haven't already got those that are in date, but at least this way you're saving £125 on the cost of the actual consultation itself. So well worthwhile using that if you're planning to book in for a consultation shortly. So as long as you book the appointment before the end of the month, then you'll be eligible for that. There's also a number of fertility funding options that exist. So we work with Access and Assured. It's worth having a look on our website to see both of these organisations and how they work. They all work slightly differently, but essentially it's about trying to make sure that you can access the fertility treatment when you need it. And there is a 0% finance option available with both of these organisations. So something else to consider. Now, we've kind of rattled through all of that. I know it's been nearly an hour of me talking, but that still feels like that was quite a whistle-stop tour. So one of the things that we really want to sort of get across to you is that we are aware that fertility treatment can be quite a stressful thing to go through. Most people don't want to be here, but when we find ourselves here, it's important that you feel supported. So we take wellness very seriously at Herts Essex. We have all of our socials try to include an element of this in it as well. And we want you to be able to reach out to us if you have any concerns, if you need any additional support. We can always signpost you to the best places to get that support. And also, obviously, we ourselves want to be able to offer that to you. And I said earlier about the sort of importance of being fit for fertility. We have a specialist fertility dietitian who works alongside us, which is Alex, and you can see her details here. There's a QR code and you can see the access to her website links too. She can do one-on-one virtual sessions. She can work for you as an individual or as a couple to try to give you dietary advice to maximize your chances of being as healthy as possible. We know if your body is as healthy as it can be, it will produce the best sperm and eggs that it can, and that in turn will give you the best chance of a healthy pregnancy. It may be that no amount of eating well is going to completely undo whatever damage you may be experiencing or problems that you may find in your fertility, but it will only ever help if we can try to get you as healthy as possible. So do make use of Alex if you are feeling that that's something that would be helpful to you. So to sum up, we have over 36 years of experience at Herts Essex, and with the sort of advances that have come into the field over the last few years, we're able to offer a 7-day-week service. We have all the safety measures that you would expect from a modern IVF lab. And as part of that, we therefore now have these 8,000 babies that are out there, and we'd love to add your children to the list. You know, we have a really quite tight-knit family here. We see many of the patients that we've treated over the years come back. Every year we have a party where we invite the babies born in the last year to come back through to show off your beautiful babies and have a chat with all the staff that supported you through. And we want to support everyone through their treatment and care. We are aware that not everyone's fertility journey and fertility treatment will end with the outcomes that we want, but what we want to make sure that you feel that you've got is supported care throughout and given the opportunity to explore whatever options might be appropriate for you. So, as I say, do make the most of the support that we have. The other thing is, of course, free parking. Our clinic has a small car park out front. We're quite easy to get to, and it sounds glib, but it is actually quite an important factor. When you're choosing a fertility clinic, you need to make sure that you like the sort of vibe of the clinic, that you feel like welcome there, but also there's nothing worse than the stress of not being able to get to your appointments or to be worrying about where you're going to park. So do take that into account. We have a lot of feedback from people saying that that's something that they hadn't thought about before, but actually did make a big difference. So if you'd like to come and sort of see the site, obviously you can do that, but I'm also going to show you a video shortly that hopefully will give you a clearer picture of where we are and who we are. As I said right at the beginning, we value your feedback, so please do complete the short survey that we'll send out to you to let us know what you thought of the talk tonight. If there's anything you'd like to have seen included that we didn't include, let us know. We update the slides that we do every time, so we can include that for the next group of people. But also use the Q&A to let us know if there's anything we missed out that you'd like an answer to right now. We will go through those this evening once we've finished wrapping up here. We have our social media channels, of course, so do feel free to follow us on there. We try to post things that are informative, but also things that sort of showcase what we're like as a centre and the kind of experience that you might have if you come through as a patient with us. So that's all on there. To book an appointment, you can call the number that's shown here, or you can email inquiries@hertsandessexfertility.com. As I say, you've got that discount code at the moment. You don't need a code, you just need to tell us who you are when you call, and we will be able to apply that for you. New consultation appointments are usually available within the next 4 weeks. I think at the moment it might be ever so slightly less than that because we have been able to add a few more to the diary. So if that's something you'd like to do, give us a call and we'll get you booked in for the next convenient one. The Q&A is still open, so please do use that in the next few moments. And then if you just bear with me, I'm going to now try to load up for you the video that we have of the clinic so that you can see what it all looks like. So I just need to stop sharing my screen and then reshare so that you can see the video. So bear with. Of course, now it won't do it. Nope. There it is. Perfect. So I will play that for you now. Okay, so thank you very much for taking the time out this evening to attend the presentation. As I say, please continue to use the question and answer section to ask any questions you have. We'll work through them all before we log off this evening. And if you have anything that sort of comes to you after this presentation, after you've gotten off the call later, please feel free to give us a ring tomorrow or to send us an email, and we'll answer any questions that you might have. Okay, so I'm going to turn off my mic and camera now and get on with the questions, but I hope that was useful for you all. Thank you.